Welcome to Section 6. In this section, we will be discussing various first aid procedures. Head, spine, and neck injuries. A patient with a head, neck, and spinal injury should never be moved if his or her life is not in danger. The life is only in danger if the patient is not breathing and has no pulse. The first aider must understand the mechanism of the injury, get the full story or history from bystanders, and if the casualty is conscious, allow him or her to explain the course of events. Study the emergency scene for clues to establish the nature of the injuries. Common symptoms. The following symptoms could be present: changes in consciousness, vision and breathing problems, nausea and vomiting, inability to move a body part, steady headache, tingling or loss of sensation in hands, fingers, feet, or toes, blood in the ears or nose, seizures, severe pain, pressure or bleeding in the head, neck or back, bruising of the head, and loss of balance. Treatment. When the patient must be moved, it has to be done as a unit, with the spine in a straight line. 4 first aiders, or helpers, kneel on one side of the patient that has been immobilized. 1 first aider, the leader, holds the head of the injured in his hands, while the next places his or her hands on the shoulder and side of the chest. The next first aider places his or her hands on the hip and the outer part of the upper leg, while the last first aider controls the feet. The first aider at the head is in charge and on his or her command, and on the count of 3 moves the patient as a unit onto his or her side. A stretcher is placed under the patient, and on the count of 3, from the leader, rolled back onto the stretcher. These are considered critical injuries, and take precedence over the rest, and emergency services should be called. Do not move the patient, unless you are positive there are no spinal injuries. You must always prevent any further damage to the spine, and never move your casualty if it is not necessary. Spinal nerves, if pinched, can cause paralysis. Conditions when casualty can be moved. When casualty is not breathing and has no pulse. When conditions dictate that the casualty has to be moved, for example, if the car is on fire. Procedure when transporting. Make sure the patient is fully immobilized, and prevent further injury. Move the patient as a unit, with the head, neck and shoulders aligned. Check the patient's airway while transporting. See that all equipment stays fastened. If you have to move the casualty, the general rule is, don't move an injured person. However, some situations require you to break this rule. The risk of moving. You risk further injuring the victim when you move an injured person. Every move carries the risk of spinal or neck injuries that can result in permanent paralysis or death. Even if it does not appear, the victim suffered neck or back injuries. Such injuries are often invisible. When to take the risk? The victim is in more danger remaining where he or she is. For example, the victim is in a burning building. The victim is in an area off limits to rescue teams. For example, the victim is inside a radioactive area, where setting rescue workers up for access would take so long as to be life-threatening. It is impossible to aid the victim in his or her present location. For example, the victim is unconscious inside a vessel, and you must use an extraction harness to get the victim out where treatment is available. When directed by the emergency personnel, such as a company nurse, emergency medical technician, or firefighter, to move an injured person. The 2 key reasons for moving somebody with a spinal injury are: to turn the person onto her back, in order to resuscitate her, and to turn her into the recovery position, if she is unconscious, and in a position that does not allow her to maintain a clear airway. Neutral position. The best position for a person with a suspected neck or spinal injury is the neutral position. Here the head is in line with the neck and spine. To move a person into the neutral position, grip the head firmly over the ears, and move it slowly into line. Once in this position, do not give up this support until medical help arrives to take over from you. Only use this technique if you have been trained to do so. Moving the person with a spinal board. To get the person onto a backboard safely, you must log roll the injured person to keep the neck stable. Using this technique, you roll the person to one side and slip the backboard under the victim. Then, you roll the person in the other direction. If at all possible, use a stiff board or medical backboard underneath the injured person while a second person maintains the neutral position of the injured person's neck. If time permits, splint and stabilize injured or fractured extremities Before moving an injured person, you may need to use your own clothing, or that of the victim. If moving is so vital that you cannot wait for rescue personnel, then use whatever is on hand to get the job done. Move the victim to a safer area, and call for help. Remain with the victim, and provide additional first aid at the safer location. Moving the person, without a spinal board. Use the log roll technique. One of the most effective ways of turning a person over is the log roll technique. Log roll can also be used to turn somebody with a spinal injury onto her side, as an alternative to the recovery position. It is also commonly used to move people with other injuries, such as a broken leg or pelvis, onto a stretcher or blanket. Ideally, 6 people should be used to carry out this technique, with one person taking the lead and control of the head. Place your hands over the ears with your fingers along the chin. Hold the head in the neutral position. Ask the supporters to gently move the arms to the side of the body and to move the legs together. Ask the supporters to support the spine and limbs and to follow your commands. Roll the casualty like a log, keeping the head and chin in line with the neck and spine. If you are by yourself and the injured person is not breathing, do not waste time searching for help. Turn the person as carefully as you can, with any help available to you. General precautions. Do not attempt to set a broken bone or move it back into place. Simply try to keep it immobile while you are moving him. Do not clean a wound with peroxide, bleach, or any harsh chemicals. Do not even attempt to clean the wound, unless it is an acid or caustic burn. In that case, flush the wound with water. Do not slap the victim in an effort to keep him or her conscious. It is not important that the victim is conscious, only that he or she continues breathing until help arrives. Do not give anything to eat or drink. If the victim is thirsty, provide a small amount of water. Conditions when casualty can be moved. When casualty is not breathing and has no pulse. When conditions dictate that the casualty has to be moved, for example, if the car is on fire. Procedure when transporting. Make sure the patient is fully immobilized and prevent further injury. Move the patient as a unit, with the head, neck and shoulders aligned. Check the patient's airway while transporting. See that all equipment stays fastened.
Okay, we're going to be demonstrating the lock roll. Sydney, you are at the head. Matapelo, you are above the hip and below the knee. And I'm going to be at the shoulder and at the hips. Now what we do is we crisscross the patient's arm. There we go. Now the reason why we're doing the lock roll is for head, neck and spinal injuries, to protect the airway. The person at the head is the person in charge of the lock roll.
First aiders, we lock roll in 3. 1, 2, 3. First aiders, lock roll back. 1, 2, 3.
Head injuries. Injuries to the head are always regarded as serious because they can inflict damage to the brain and spinal cord, as well as damaging the bone and soft tissue. As a result, head injuries can be devastating to the patient. Head injuries can be invisible to the eye. In many instances, a patient who appeared unaffected after an incident suddenly collapses, with life-threatening symptoms some hours later. This may be due to the sudden movement of the head forward and backward, on impact, which may cause a small bleed in the brain, that eventually increases and applies excessive pressure on the brain tissue. Such injuries can easily mislead the first aid provider by not exhibiting the expected signs and symptoms immediately after an incident. As a first aid provider, you should always take head injuries seriously. Always check the patient's response and whether they have any alteration of consciousness. Look at the history of the incident and the mechanism of injury. If, in your opinion, the patient's conscious state is altered, or the incident had the potential to cause serious injury, assume the worst and treat as a serious head injury. Understand the mechanism of the injury. Get the full story or history from bystanders, and if the casualty is conscious, allow him or her to explain the course of events. Study the emergency scene for clues to establish the nature of the injuries. Head injuries can be either open, for example a head injury with an associated head wound, or closed with no obvious sign of injury. Symptoms and signs. Bruising and or redness. Dazed or confused reactions. Patient may vomit. Unusually slow pulse rate. Pupils dilate irregularity. Visible or obvious fracture. blood in or fluid coming from nose or ears, and unconsciousness. Treatment for head injuries. If a head injury is determined or suspected, maintain open airway. Suspect cervical, also known as a neck injury. Position your patient with head lifted if head injury. Do not put anything under the head. Make sure that the injured side of the head faces the ground so that fluid can drain. Control any bleeding. Dress any wounds. And treat for shock. What not to do. Leave the victim alone, especially when they is sleeping. Wake them up every 3 to 4 hours and have them answer simple questions to make sure there is no brain injury, such as a concussion. When to seek medical attention. Call the medical emergency services if the victim exhibits seizures, dizziness, vomiting, nausea, or obvious changes in behavior. Unconsciousness. It is important to remember that the brain is the control center of the body and controls the working actions and functions of the body. If a patient is unconscious, but breathing normally, then you should place them into the recovery position to protect their airway. It is best to place your patient in a stable, comfortable, and safe position. The recovery position involves rolling the patient onto their side with their head tilted back. By doing this, the tongue is kept clear of the airway, and any vomit is able to drain and not obstruct the patient's airway. What about injuries? At this stage, do not worry too much about the patient's injuries. Your main priority is to protect the airway, assist with breathing, and control life-threatening bleeding. Once the person has been placed in the recovery position, you can start assessing and treating any other injuries which you have found. The advantages of the recovery position. The airway remains open, and tongue cannot block it. Gravitational drainage can take place, for example, vomit will be expelled. The pulse, especially the carotid, can easily be monitored. And it is a safe and comfortable position for your patient. Treatment. Provide and maintain an open airway. Treat the cause. Place in recovery position. Treat for shock. Seek medical help. And monitor vital signs every 2 minutes. Fainting. Fainting is a brief and sudden loss of consciousness, normally due to a reduction in the blood flow to the brain. Normally, a faint results in a person falling to the floor. The brain requires a constant supply of oxygen and nutrients. This supply is provided by the blood. There are numerous things that can interrupt this supply. For example, blood tends to pool in the legs during periods of inactivity, for example, standing or sitting for long periods of time. If you suddenly stand up, the heart has to work harder to pump this blood upwards, against gravity. This can cause a head rush in some people, with a feeling of dizziness. However, in other people, this interruption in the blood supply to the brain causes them to lose consciousness, called a faint. Generally, once a person has fainted and fallen to the floor, they regain consciousness very quickly. This is because when lying down, the heart finds it easier to pump blood to the brain, as it is not working against gravity. There are some telltale signs that someone is going to faint. They may go very pale white and look unsteady on their feet. Also, they may complain of feeling lightheaded or funny. Treatment for a faint. If someone complains of feeling faint, you should lie them down on the floor with their feet elevated until they feel better. This is to prevent any injuries occurring if they do fall. If someone has fainted, you should raise their legs to improve the blood supply to the brain. If they have fallen, check for any injuries, such as fractures or head injuries. Once they recover, help them sit up gradually. Do not let the patient stand up straight away, as they may just faint again. If the patient does not wake up, check to see if they are breathing. If they are, roll them onto their side in the recovery position and call an ambulance. If the patient recovers fully and has not suffered any injuries, there is no need to call an ambulance. If they are not sure what caused the faint, or have not fainting before, then it is advisable for them to seek medical attention. Rib fracture. Ribs are pretty hard to break. They are surrounded by strong muscles and usually can take a lot of abuse before they crack. The elderly can get broken ribs easier than younger adults. Kids have more flexible bones. Most broken ribs, including children, come from vehicle accidents, but they are also common from falling off horses, sports injuries, and falls. Most of the time, the broken rib is only broken in one place, and is an incomplete fracture, meaning not all the way through the bone. Completely broken ribs may or may not move out of place. If they do move, they are called displaced rib fractures and are more likely to puncture lungs or damage other tissues and organs. Ribs that stay in place, usually ribs that are not completely broken in half, are called non-displaced rib fractures. Broken rib complications. The most common complication of broken ribs is not being able to take a deep breath, because it hurts. If you do not breathe deep enough, mucus and moisture can build up in the lungs and lead to an infection such as pneumonia. Displaced rib fractures can damage other tissues or organs and sometimes lead to collapsed lungs or internal bleeding. Treatment. Do not wrap tight bandages around the chest. Support the chest with a pillow. Manage shock and monitor vital signs. A change in breathing can indicate the development of a pneumothorax, also known as a collapsed lung. Bone injuries or fractures. Fractures are classified as open and closed fractures. A fracture is when there is movement of the bone, where there should be no movement. There are two types of bone injuries or fractures, namely, open fractures. Broken bone tears through the skin, causing an open wound. Closed fractures. Skin is not broken. Common symptoms. The following symptoms could be present. Pain or tenderness at place of fracture. Inability to use limb. Swollen. Discolored. Irregular line of the bone, under the skin, known as a deformity. Shock. Crepitus, the grating noise as the broken end of the bone, rubbing against each other. Sometimes shortened. The following rules apply to splinting a fracture. Secure above as well as below the fracture. Secure above and below a joint. The splint that is being used must be hard and long enough to support the fractured bone. Always support the long bones. Splint the fracture in the position you find it. Always check for pulses, capillary refill, comfort, and movement. Always feel for a pulse below the injured part. When no pulse is detected, seek medical assistance immediately. Do not try to move a patient with a severely broken bones, unless it is absolutely necessary. Calling emergency services is the best course of action in this case. However, if you must move the patient, you must immobilize the injured body part. One way is to splint it, but only do this if it can be done without hurting the patient, and always attempt to splint the part in the position you found it. Splint the injured area. You may use another body part, like an injured leg to an uninjured one, or an injured arm to a chest. This is called an anatomic splint. Make a soft splint from folded blankets or towels, or use a triangular bandage to make a sling. A sling is another type of a soft splint, which is used to support an injured arm, wrist, or hand. Use folded magazines or newspapers, cardboard, or metal strips, to support the injured body part with a rigid splint. Use several folded triangular bandages to secure the injured body part to the splinting material, tying them securely, but not too tight. Raise the injured part, and prevent the patient from getting chilled or overheated. Pelvic fracture. The pelvis is surrounded by strong muscles, and you will seldom find open fractures. Direct or indirect impact can cause pelvic fracture. Occasionally, bone fragments can lacerate the rectum, vagina, bladder, blood vessels, or uterus. As a result, 40% of the patients will develop hypovolemic shock. Signs and symptoms. Severe pain in the pelvic area, and with movement of the legs. Tenderness on firm compression, and palpitation. Treatment. Stabilize pelvis, with broad bandage. Place a rolled blanket between the legs of the patient, and tie the legs together. Turn patient, as a unit onto a full trauma board. Monitor vital signs. Manage shock.
Okay, here we're going to demonstrate how to secure the pelvis if there's a pelvic fracture. Demonstrate what we're going to do to the patient. You're going to need, if you want to use it, a splint, a sheet, and plus minus 5 triangular bandages. So what we do, just push the sheet in underneath the patient. Alright, and then we just zigzag this underneath the patient. There we go. Make sure that it's more or less 50-50. There we go. And bring the ends together. And we twist. Go. Secure on top. And then we wet the knot. This is just to make sure that your knot doesn't slip. And then we pull nice and tight, and we tie it off again. All right. The triangular bandages. Sydney, can I ask you to open one for me so long, please? Matapelo, extra bystander. Here we go. Keep it as a broad bandage. Okay, so all we do is we just open them nicely. Okay, they folded it like this, so you need to quickly fold broad bandages. There we go. Okay, so the rule says above a joint. Now here comes the trick. Usually when we tie on the legs, because there's a fracture, just check your capillary refill, or you can check for pulses on the feet if they are present. So, tie above the knee joint. We tie below the knee joint. Okay, remember to check your pulses and your capillary refill. Okay, and then we have another joint here at the bottom, which we can use here at the ankles. There we go. Okay, but now this one, because it's a long bone, we are also going to support the long bone. So what I suggest is just to pull this one into position first. There we go. And then may I have another triangular bandage, please? Oops, sorry. There we go. Ankles. And you can either tie it off like this, or you can add another bandage and tie the feet properly nice together as well.
Sprains. It happens that a person stretches a muscle, ligament, or tendon beyond its capacity. The tissue under the skin has been damaged, and internal bleeding exists. A closed wound occurs under the skin. This is called a sprain. Common symptoms. The following symptoms could be present. Swelling at the joint. Sprains occur when the ligaments surrounding a joint are pulled beyond their normal range. Sprains are often accompanied by bruising and swelling. Treatment. A cold compress, for example an ice pack covered in a cloth, must be put onto the injured part to control blood circulation. The injured part needs to be elevated to reduce blood flow and pressure in the body part. The body part must be immobilized with a stabilizing bandage. Dislocations. A dislocation is the displacement of bone ends at a joint. A joint is stabilized with ligaments and muscles, which can easily be torn during excessive movement. The joint can or cannot be deformed and may be mistaken for a fracture. Dislocations involve mostly the shoulder, elbow, finger, jaw, wrist, knee, or hip. Common symptoms. Pain and pressure at the joint. Loss of movement and possible deformity, swelling and discoloring. Treatment. Never attempt to replace or reposition a dislocated joint. Improvise support and comfort using padding or a pillow. Adhere to the basic principles of immobilization. Bleeding. Bleeding is categorized in two categories, namely external bleeding and internal bleeding. Whenever bleeding must be stopped, surgical gloves need to be worn for protection. The amount of blood in an adult's body is determined by his size, and weight. An approved method to determine the amount of blood in a person's body is by dividing his body weight by 10. The answer indicates more or less the amount of blood in that person's body in liters. For example, 76 kg divided by 10 equals 6 liters. The person's life is in serious danger when quarter of the blood volume is lost. External bleeding. Note: bleeding must be controlled so that the body can stop the bleeding. Bandages and dressings only minimize bleeding and prevent infection. External bleeding is caused by wounds and is classified as arterial bleeding. The artery transporting blood from the heart is damaged. The blood is bright red in color and is lost from the body in a squirting action. The best way to stop such bleeding is by applying direct pressure on a pressure point between the injury and the heart with the hand. A pressure pad and bandage may also be used. Venous bleeding. The vein transporting the blood back to the heart is damaged. The blood is dark red in color and is lost in a flowing out action from the body. The best way to stop such bleeding is by applying direct pressure to the wound with clean cloths and bandages. Capillary bleeding. Blood seeps from a superficial wound and is bright red in color. The best way to stop such bleeding is by applying direct pressure onto the wound with clean cloths and bandages. Treatment for external bleeding. If cavities are involved, apply wound dressing with moderate pressure. Localize the bleeding, for example, position the patient. Treat for shock. If extremities are involved, direct pressure. Elevate if possible. Pressure point. Treat for shock. In most cases, the average person may find they are not prepared and unable to administer the best first aid possible, because they lack the knowledge of various types of dressing and bandage materials available, or the proper use of these important first aid items. A dressing is used to cover a wound, to assist with control of further bleeding, and prevention of further contamination. There are 3 types of dressings that should be part of any first aid kit, namely adhesive, pressure, and gauze dressings. The purpose of a dressing is to control bleeding, prevent infection, absorb blood and wound drainage, and to protect the wound from further injury. Types of dressings include pads, sterile eye pads, sterile gauze pads, sterile non-adherent pads, and burn dressings. A burn dressing is a sterile pad soaked in a cooling gel. Always make sure that the pads you are using are sterile, or as clean as possible, as they are applied directly to the wound. The dressing should also be absorbent, to soak up body fluids such as blood or any discharge. The dressing must be soft and compressible, so pressure can be distributed over the wound. Always make sure the dressing is non-fluffy, so the material will not stick to the wound. Please do not use cotton wool directly on a wound. There are different types of bandages. Their sterility is not necessary, as they are used to secure a dressing. They should, however, be as clean as possible. Gauze roller bandages are absorbent, breathable, and often elastic. Elastic bandages are used for sprains, and as pressure bandages. Adhesive, elastic roller bandages are highly effective pressure bandages and durable, waterproof bandaging. Triangular bandages are used as slings, tourniquets, to tie splints, and many other uses. The most used type of bandage is the gauze bandage. It is a simple woven strip of material, which can come in any number of widths and lengths. A gauze bandage can be used for any bandage application, including holding a dressing in place. A triangular bandage is a piece of cloth, cut into a right-angled triangle. This is felt by many trainers to be the most versatile of the bandages available, as it can be used fully unrolled as a sling, folded as a normal bandage, or for specialist bandages such as on the head. Sometimes dressings and bandages are combined, in which case they must be sterile. Adhesive bandages like band-aids and sticking plasters are of the most used items in a first aid kit. Examples are straight adhesive bandages, and butterfly, or knuckle bandages. The main types of bandages are triangular, and roller bandages. They are used to secure the dressing and assist in control of bleeding. Provide support to a limb or joint. Hold splints in place and immobilize parts of the body. If a bandage is applied, it should cover the whole dressing, and do not remove the bandage once it is in place. If it becomes saturated with blood, apply another one on top, so that clotting that has already taken place will not be disturbed. There should always be a pulse distal to the side of the bandage. Where possible, keep the nail beds uncovered, to enable detection of inadequate distal circulation. Should signs of inadequate distal circulation be visible, as observed from skin temperature and color, loosen the bandage, and reapply. An occlusive dressing is an airtight dressing that can be used to treat a sucking chest wound, in which air is sucked into the chest cavity, collapsing the lung. This is known as a pneumothorax. For this use, an occlusive dressing should be taped on 3 sides only, to create a one-way valve. Petroleum gauze, also used as non-adherent dressing, can be used as an occlusive dressing, as well as half of any gauze wrapper, since the inside is sterile and airtight.
Internal bleeding. Internal bleeding can usually not be seen, and a patient can bleed themselves to death without spilling one drop of blood. Internal bleeding can, however, be seen when blood flows from inside of the ear, from the lungs and abdomen, intestines, and bladder. The patient will be cold, clammy, very weak, pale, and dizzy, have a rapid pulse, breathe rapidly, and will complain of pain in the injured area. The patient must be laid down, feet elevated not more than 20 centimeters, and are covered with a blanket. Bleeding from inside the ear should never be stopped. Look out for or find out history of injury that caused internal bleeding. History of a medical condition, for example, ulcer, which may cause internal bleeding. Pain and tenderness around the affected area. Swelling and/or bruises. Signs and symptoms of shock. Blood may appear from one of the body's orifices. Blood-speckled froth at the mouth. Treatment for internal bleeding. Cavities. Localize the bleeding, for example, position the patient. Treat for shock. Extremities. Apply ice indirectly. Elevate if possible. Treat for shock. Wounds. Wounds are classified as open and closed wounds. Treatment of the casualty and aseptic principles. Aseptic means preventing infection. First aiders must comply with the aseptic principles and only use sterile items. Sterile objects become unsterile when touched by unsterile objects. The skin cannot be sterilized and is unsterile. If the wound is not deep and gapes slightly, the first aider may find that he or she only needs to hold the wound edges together, dress, and bandage the wound. At times, however, it may be difficult for the first aider to decide whether a wound needs medical care. The first aider may ask the question: does this wound need suturing by a medical practitioner? An open wound condition requires medical treatment when the following occur: blood spurting from a wound, bleeding that persists despite all efforts to control it, an incised wound deeper than the outer layer of the skin, crushed nerve, tendon, or muscle, skin broken, bite human or animal, foreign object embedded deep in the tissue, foreign matter in a wound, not possible to remove by washing. Any other open wound where there is doubt about what to do.
Open wounds. Open wounds occur where the skin's tissue has been damaged or torn. External bleeding takes place, and the bleeding has to be stopped, according to the treatment for external bleeding. The injured part needs to be elevated to reduce blood flow and pressure in the body part. The body part must be immobilized with a stabilizing bandage. Foreign objects may be stuck in the patient's body, and should never be removed but rather stabilized, with a ring pad or stabilizing bandage. Examples of open wounds are incisions, lacerations, punctures, animal bites, contusions, abrasions, bruises, and ballistic wounds. Incisions. Incisions, commonly called cuts, are wounds made by sharp cutting instruments, such as knives, razors, and broken glass. Incisions tend to bleed freely, because the blood vessels are cut cleanly, and without ragged edges. There is little damage to the surrounding tissues. Of all classes of wounds, incisions are the least likely to become infected, since the free flow of blood washes out many of the microorganisms or germs that cause infection. Lacerations. These wounds are torn, rather than cut. They have ragged, irregular edges, and masses of torn tissue underneath. These wounds are usually made by blunt objects. A wound made by a dull knife, for instance, is more likely to be a laceration than an incision. Bomb fragments often cause lacerations. Many of the wounds caused by accidents with machinery are lacerations. They are often complicated by crushing of the tissues as well. Lacerations are frequently contaminated with dirt, grease, or other material that is ground into the tissue. They are therefore highly likely to become infected. Punctures. Punctures are caused by objects that penetrate into the tissues, while leaving a small surface opening. Wounds made by nails, needles, wire, and bullets are usually punctures. As a rule, small puncture wounds do not bleed freely. However, large puncture wounds may cause severe internal bleeding. The possibility of infection is great in all puncture wounds, especially if the penetrating object has tetanus bacteria on it. To prevent anaerobic infections, primary closures are not made in the case of puncture wounds. Abrasions. Abrasions are made when the skin is rubbed or scraped off. Rope burns, floor burns, and skinned knees or elbows are common examples of abrasions. This kind of wound can become infected quite easily, because dirt and germs are usually embedded in the tissues. Contusion. This wound is normally caused by a blunt object, which bruises the surrounding tissues, and could cause a fracture. Bite wound. This wound is normally caused by animal bites, for example, dog, cat. Try to keep the animal that caused the bite for further tests. Ballistic wounds. A bullet or a projectile caused this wound. Damage normally caused internally. Avulsions. An avulsion is the tearing away of tissue from a body part. Bleeding is usually heavy. In certain situations, the torn tissue may be surgically reattached. It can be saved for medical evaluation by wrapping it in a sterile dressing, and placing it in a cool container, and rushing it, along with the victim, to a medical facility. Do not allow the avulsed portion to freeze, and do not immerse it in water or saline. First aid for life-threatening bleeding, including amputations. Bleeding from a wound is considered life-threatening if the flow of blood is continuous, and if the volume of blood loss appears large. A manufactured tourniquet should be used first for life-threatening extremity bleeding, and should be placed as soon as possible after the injury. A self-made tourniquet can be used if a manufactured tourniquet is not available. Tourniquets can be improvised from sticks, pipes, and triangular bandages, taking care not to use any thin cloth, or materials like shoelaces, as these can cut through the skin when tightened. Tourniquets are applied 10 centimeters above the injury, at least 5 centimeters in width, and not removed until the patient arrives at the hospital. It is important to record the time of placing the tourniquet, and informing the emergency personnel, or doctor of the tourniquet that has been placed. Do not cover the tourniquet with any bandages, or clothing to make it easily visible to the emergency personnel, and doctors. If a tourniquet is not available, or not controlling the bleeding, direct pressure, with the adjunctive use of a hemostatic dressing, if available, should be used to treat life-threatening bleeding. Hemostatic agents such as Celox and Quick Clot are designed to promote rapid blood coagulation, in the event of a traumatic wound involving an arterial bleed. Training should be done on hemostatic dressings, before they are used by the first aider. Wounds with life-threatening bleeding located on a body part, that is not on the arms or legs, such as the head, neck, chest, abdomen, shoulders, or hips, cannot be stopped with a tourniquet. Tourniquets are also not applied over a joint. These life-threatening wounds are packed with materials like gauze, or any other clothing. Packing the wound means to take the material, and place it tightly into the wound. You then apply direct pressure, and a compression dressing. Treatment for amputations. After bleeding is controlled as mentioned. Collect amputated part, keep dry, do not wash or clean. Seal the amputated part in a plastic bag, or wrap in waterproof material. Place in iced water, do not allow the amputated part to come in direct contact with ice. Freezing will kill tissue. Ensure the amputated part goes to the hospital with the patient. Often the part can be reattached using microsurgery. If bleeding occurs through the existing dressing, place a second dressing over the first, leaving the existing dressing in place. Maintain direct pressure over the bleeding area as much as possible. Avoid disturbing the bandage or pad once the bleeding has been controlled. Wounds can be cleaned with clean water or a saline solution.
My name is Av Rios, and I'm a paramedic with Lansing Mercy Ambulance on behalf of Expert Village. In this clip, we're going to go over tourniquet use to help control blood loss. Tourniquets should be used only as a last resort for blood loss control. A tourniquet should only be applied once you've came to the conclusion that you are not able to control the blood loss with direct pressure, elevation, and pressure point combined. Once you realize that that is not controlling the blood loss, what you're saying to yourself is, I'm now going to put a tourniquet on. This tourniquet is going to cut off complete blood flow to the extremity. You're going to, by lacking the extremity from getting the blood flow it needs, it's going to actually start to die and tissue necrosis will begin. What that means is by putting on the tourniquet, you're saving the person's life from the blood loss, but you're sacrificing that limb, and it should have to be amputated if put on correctly. This is an example of a commercial product that you can buy. Anything can be used similar to this, such as a piece of clothing or belt. Once you've opened this from the package, you will have the triangular bandage. What this is very similar to is a bandana. I'm not going to open it all the way up because for the sake of this, I want it to look just like this. What you want to have is approximately 2 inches wide of material. You always want to go approximately 2 inches above the injury site also. For the sake of this example, we're going to say that I am losing blood from just above my knee here. It is an arterial bleed, which means it is bright red squirting blood. I've been unable to control it with direct pressure and elevation of my leg, and by pushing on my femoral artery right here, I was still not able to control the blood loss. I then move into my tourniquet. It's important to remember the 2x2 rule. If this is my injury site, you want to go 2 inches above the injury site, and you want to go have a material to use your tourniquet approximately 2 inches wide. So what you want to do is put it right above the injury site. You then want to make sure that this is extremely tight and come up to the top and make a small knot and try to get that as tight as you can. You're not able to actually pull this tight enough to completely occlude the blood flow. It's very important that this is extremely tight, because if you only put it on partially, what you're going to do is squeeze the blood vessels, which is still going to have blood flow and going to cause the bleeding, but it's actually going to increase blood flow because the body's going to think that it's having a lack of the blood, so it's going to try to increase the blood flow to that injury site. So it's very important that if you decide to put on a tourniquet, you're going to completely occlude all blood flow to the extremity distal of that spot. Next, you want to use something. I'm going to use a pencil for this. You can use a pen, anything long, a little bit hard. You can even use a stick. Just set it right over the injury site. What you're then going to do is just wrap the ends around like this. And give it another tie here. This is just tying it in place. What you're now going to do is start to actually spin it around. As you spin it, it's going to tighten here. I'm going to stop it here for the sake of I don't want to cut the blood flow off completely to my leg. But that'll be sufficient enough. Once you have it as tight as you think you can go, or to the breaking point of whatever object you use, what you then want to do is secure it in place. If I let this go, it'll start to spin itself around again and release. So what I want to do is lock it in place. I do this by taking my 2 ends that I have left and wrapping it around and then tying itself back together again. Keep in mind it's going to release just a little bit, but it should stay in place.
Closed wound. A closed wound occurs under the skin. The tissue under the skin has been damaged and internal bleeding exists. A cold compress, for example, ice pack covered in a cloth, must be put onto the injured part to control blood circulation. The injured part needs to be elevated to reduce blood flow and pressure in the body part. The body part must be immobilized with a stabilizing bandage. Examples of closed wounds are muscle strains and joint sprains. Cuts. Cuts or open wounds are a result of damage to the tissue, which causes slight or severe bleeding depending on the degree of the injury and the rate of blood lost. Common symptoms. The following symptoms would be present: restlessness and anxiety, progress of shock, pale, cold, and clammy skin, rapid pulse becoming weaker, faintness and dizziness, and shallow breathing, yawning, gasping for air. Treatment. Wash your hands. Press the wound with thumb and fingers, holding cut edges together if necessary, until bleeding stops. Rinse wound under a tap if it is dirty. Then, using gauze, gently clean with soap and water. Work from the center of the wound outwards, using a clean swab for each wipe. Finish with some diluted antiseptic. Pat skin thoroughly dry. Carefully remove any small pieces of glass or gravel from the wound with a clean piece of gauze tweezers. For small cuts and grazes, a plaster is enough. Larger injuries need a non-adhesive dressing, secured with a gauze bandage, which you tie firmly but not so tightly that the circulation is restricted. Never put fluffy dressings like cotton wool next to the wound. They will stick to it, and it will be painful when it comes to pulling it off. Only handle the very edges of a dressing. Nosebleeds. A nosebleed occurs when blood vessels inside the nose break. Because they are delicate, this can happen easily. Treatment for nosebleeds. Let the casualty sit down. Do not let the casualty tilt their head backwards. Do not plug the nose. Advise the casualty to breathe through the mouth, and to pinch the soft part of the nose. Tell the casualty not to swallow any blood, but to spit it out, because it may cause nausea and vomiting. Press an ice pack against the bridge. After ±10 minutes, leave the nose to see if the bleeding has stopped. If not, repeat treatment for another 10 minutes. If the bleeding has stopped, tell the casualty to avoid exertion and not to blow their nose. If the bleeding has stopped, keep the head forward, and clean the casualty's face. What not to do? Tilt your head back. The injured person may swallow blood, and potentially some could go in their lungs. The patient may also start to vomit, as the blood will irritate the stomach. When to seek medical attention? Call the doctor if you cannot stop the bleeding after 30 minutes. If the nosebleed happens without a reason, or if the bleeding accompanies a headache, dizziness, ringing in the ears, or vision problems. Bleeding from the ear. Treatment for bleeding from the ear. Put the casualty in a half-sitting position with the head towards the injured side, so that any fluid can drain from the ear. Do not plug the ear. Cover the ear with a sterile dressing. Check pulse and breathing rate. Treat for shock. If the casualty becomes unconscious, but is still breathing normally, put him in the recovery position. If breathing and heartbeat stops, begin resuscitation and seek medical help. Bleeding scalp. First aid for a bleeding scalp. Control the bleeding using direct pressure. If the casualty is conscious, lay them down, with the head and shoulders slightly raised. Check casualty's vital signs at 10-minute intervals. If the casualty becomes unconscious, place them in the recovery position. If breathing and heartbeat stops, begin resuscitation. Transport to hospital. Burns. Burns are classified in the seriousness, degrees, and types burns. Degrees of burns. First degree or superficial burn. The surface of the skin has been burned, and has changed color, for example, sunburns. This type of burn usually heals in 5 to 6 days, without any permanent scarring. Common symptoms. The following symptoms would be present. No blisters. Skin has just been warmed. Skin is red, and dry. Painful. Burned area may also swell. Treatment. This type of burn is treated with cold water running over the surface of the skin, for at least 20 minutes. No further treatment is necessary. Second-degree burn, or partial thickness burn. A second-degree burn involves the top layers of skin. The dermis of the skin has been burned, and has changed color, and blisters have appeared. Common symptoms. The following symptoms could be present. The skin is red. Blisters that may open, and weave clear fluid, giving the skin a wet appearance. The area may also appear mottled. The burn is usually painful, and often swells. Treatment. This type of burn is also treated with cold water running over the surface of the skin, for at least 20 minutes. The burn must be covered with sterile bandages. And the blister should not be broken. Seek medical assistance. With this type of burn. Treat for shock. Do not use fluffy dressings on this burn wound. This type of burn usually heals in 3 to 4 weeks, and scarring may occur. Third-degree burn or full-thickness burn. A third-degree burn destroys all layers of skin, and any or all of the underlying structures including fat, muscles, bones, and nerves. This burn is critical and requires immediate medical attention. Common symptoms. The burn appears brown or black, with the tissues underneath sometimes appearing white. Blisters appear around the burnt area. Extremely painful, or relatively painless if the burn destroys the nerve endings. Treatment. All clothing, or material sticking to the skin on the burn wound, should never be removed. Clothing, and material sticking to the wound, should rather be cut loose and the burn covered with a wet cloth, or clean piece of plastic over the burned area. The burn is then covered with sterile dressings, and cold running water poured over the dressing, to cool down the burn. Seek medical help. Treat for shock. Do not use fluffy dressing on this burn wound.
Types of burns. These are examples of causes of burns. Scalds are usually caused by steam, hot foods, boiling cooking oil and water, etc. Dry burns are usually caused by a fire, the sun, cigarette burn, etc. Chemical burns are usually caused by chemicals. Where a chemical reacts with water, it should be removed first before being cooled with water. Electrical burns can have two burns, and can have effects on the heart. Thus ensure to monitor circulation and breathing.
Febrile patients. Febrile meaning, having or showing the symptoms of fever. A disease is a disorder in a human, animal, or plant, caused by infection, diet, or by faulty functioning of a process. When a person has a disease, signs or symptoms of the disorder will display. For example, hay fever causes sneezing, runny nose, and eyes, the symptoms of the disorder. The study of disease is called pathology. Pathology includes determining the cause of the known as ethology. Understanding of the mechanisms of how the disease develops known as pathogenesis. The structural changes that take place in the human body that are associated with the disease, known as morphological changes. And the functional consequences of these changes. Meaning what happens to the body as a result of these changes. Before a disease can be treated effectively, the cause of a disease first has to be identified. Fever. Fever is defined as a body temperature that is 1 or more degrees higher than normal. Normal body temperature differs from person to person, depending on the age, by the time of day, and by the part of the body where it is measured. Factors that can influence the temperature may include strenuous exercise, medicines, or even excitement, can also affect body temperature. The person's temperature can be measured with a thermometer in the mouth, ear, or rectum, or under the armpit. When the temperature is measured in the mouth, a temperature between 97 to 99 degrees Fahrenheit, or 36.1 to 37.2 degrees Celsius, is considered normal. A temperature of 100 to 102 degrees Fahrenheit, or 37.8 to 38.9 degrees Celsius, is usually called a low-grade fever. A temperature of 103 degrees Fahrenheit, or 39.5 degrees Celsius, or higher is called a high-grade fever warning. Generally, oral temperatures of 102 degrees Fahrenheit, or 38.9 degrees Celsius, or higher are fevers that may be more serious. How to measure temperature. A checklist was provided on how to measure the temperature. Step 1. The first aider must use a sterile thermometer. Step 2. Insert the thermometer into the mouth, under the tongue or armpit, or the ear. Step 3. Leave the thermometer in place for 3 to 5 minutes. Step 4. Read the thermometer where the line of mercury ends. Temperatures measured in the ear or rectum are higher than oral temperatures by 1/2 to 1 degree Fahrenheit, or about 1/2 degree Celsius, and temperatures measured in the armpit are lower by 1/2 to 1 degree Fahrenheit. What causes fever? A fever is a symptom and not a disease. Fever can be a sign that the body is fighting an infection, and may occur with viral or bacterial infections, such as ear infections, the flu, severe colds, sore throats, pneumonia, stomach viruses, or urinary tract infections. A fever may also be a symptom of other types or sorts of medical problems, such as dehydration, a thyroid disorder, or an autoimmune problem. How is it treated? When a person has a fever, it does not mean that the person has a serious illness or needs medicine. Older adults may have a serious infection and not have a fever. For low-grade fevers below 102 degrees Fahrenheit or 38.9 degrees Celsius, the person should get plenty of rest and drink lots of fluids, especially water. Dress in light, comfortable clothing. Do not cover the person in heavy clothes or blankets. Keep the room cool but not uncomfortable. Cold injuries. Hypothermia. Hypothermia means the generalized cooling of the body. It can develop quickly when the body is immersed in cold water, or more gradually when the body is subjected to a cold environment, for several hours. Signs and symptoms: altered level of consciousness, lethargy, unwilling to move, slow, weak pulse and breathing, shivering with uncoordinated muscular moving. As condition deteriorates, shivering will stop. And skin extremely cold to touch, with loss of sensation. Management: remove patient from the cold environment. Check CABs very carefully. Restrict handling to the minimum when removing wet and cold clothing. Do not massage or rub the skin to warm him up. Cover the body, not extremities, with a space blanket or direct contact with a warm body. Keep patient still and manage shock. The patient must be hospitalized. And only in case of mild hypothermia, a warm drink may be given. No caffeine or alcohol may be given. Frostbite. Frostbite is the term applied to cold injuries, where there is a destruction of tissue by freezing. It is the most serious form of localized cold injury. It normally affects the ears, nose, chin, hands, and feet. Signs and symptoms: skin appears white and waxy. Skin is icy cold, and affected part is hard to the touch. And the affected area feels numb, but there may be stinging or aching sensation. Treatment: do not massage the affected part. Start warming body parts gradually with skin-to-skin contact, or lukewarm water. Start with cold water, and gradually make the water warmer until it is lukewarm. Do not expose affected areas with dry or radiant heat. Refer to advanced medical help. Heat illnesses. Heat cramps. It is painful muscular spasms, which occur during strenuous activity, excessive perspiration in areas with high humidity, when the body loses water, and mineral salts. Treatment: do not attempt to massage the muscle. Remove the patient from the warm environment to a cooler one. Give water, or half-strength isotonic drink if available. Heat exhaustion. Definition: a condition that develops due to loss of fluids and mineral salts, for example, perspiration. If not recognized and managed, heat stroke may develop. Signs and symptoms: early signs: excessive sweating and warm skin. Later signs: cold, clammy skin, restless and or confused, shallow rapid breathing, faint rapid pulse, nausea and or vomiting. Fainting may occur. Headache, dizziness and blurred vision, muscle cramps, and very thirsty. Treatment: place person in a cool spot. Manage shock. Remove excessive clothing. Give water or isotonic drink. Heat stroke. Definition: occurs when the body is subjected to more heat than it can handle, and the normal mechanisms for regulating body temperature are overwhelmed. It is a life-threatening condition. Signs and symptoms: not sweating at all. Body temperature rises. Skin warm and dry. Confused and or delirious. Rapid breathing. Full and bouncy pulse. Vomiting. Unconsciousness or convulsions. And severe headache. Treatment: remove excessive clothing. Cool body immediately, for example, in a bath, with garden hose. In a draft, for example, wind or fan. Manage shock. Measures to prevent heat illnesses: avoid outdoor physical activities during the hottest part of the day. Avoid sudden changes of temperature, for example, air out a car before getting in. Drink 8 to 10 glasses of water when you are working in hot weather. Do not leave old people or children waiting in a car on a hot day. Insect bites and stings. Common symptoms: for most people, insect bites or stings cause only a painful swelling, with redness and itching. A bee and wasp sting, however, may cause a severe allergic reaction in some people. Look for skin eruptions, swelling around the eyes and mouth, nausea and vomiting, and breathing difficulties. When these signs occur, seek medical help immediately. Treatment: ask the person if they have medication that they take for such a reaction, and help them to take the prescribed medication, if it is available. Apply ice wrapped in cloth. When the stinger remains in the skin, remove it by carefully scraping it, and its attached poison sac from the skin. Do not use tweezers, or anything that may squeeze more poison into the body. If there is swelling in the mouth, or if there is difficulty breathing, watch the person closely. Place him in the recovery position, or any position that makes his or her breathe easier. Seek medical attention immediately. Poisoning. A poison is any substance that can cause illness or death when it is absorbed into the body. An antidote is a substance that acts against a poison to offset its effects. You will need as much history about a poisoning accident as possible, so that proper first aid can be started without delay. Poisons enter the body in 4 ways. Inhalation, through breathing. Injection, by puncture into skin. Absorption, through skin. Ingestion, swallowing. General signs and symptoms of poisoning. Distinctive smell of poisons, evidence of containers. The nervous system may be affected, causing slurred speech or drooling, impaired vision, uncontrolled muscle spasms, loss of balance, or paralysis. Shock may develop within minutes, hours, or even days. Level of consciousness will deteriorate, for example, dizziness, unconsciousness. Breathing may be affected. Difficult due to swelling, gurgling due to excessive saliva or fluids on the lungs. And the skin becomes cold, clammy. Treatment. Safety first. Gather information from the patient, bystanders, family, or the environment and try to identify the substance. Check the circulation, airway, and breathing, if necessary, and manage according to the assessment. Contact the nearest poison center or emergency medical service. Manage shock. Common symptoms. If the history does not reveal what poison was taken, or by what means it was taken, the signs and symptoms may be helpful in determining how the poison was taken. The patient could have the following symptoms. When taken by mouth: nausea, abdominal cramps, and vomiting. Discolor the lips. And cause burns in the mouth, or leave an odor on the breath. When absorbed through the skin. Reddening of the skin. May affect consciousness. Breathing. And pulse irregularities. When injected through the skin. Irritates the point of entry. Affect consciousness. Breathing. And pulse irregularities. When inhaled. Respiratory problems. Consciousness. Pulse irregularities. Coughing. Chest pain. And headache. Treatment. Call a Poison Information Center at Johannesburg 0116422417, or Cape Town 0216895227, or a doctor, and follow their advice. Swallowed poison should not be diluted. Wipe and remove any poison or corrosive residue from the person's mouth, and do not induce vomiting, unless on advice from the Poison Information Center. Inhaled poison such as gases should be cleared from the lungs as soon as possible and the person removed to fresh air. If breathing stops, continue with artificial resuscitation. Absorbed poisons such as liquid or powdered chemicals must be removed from the skin as quickly as possible by flushing the affected area with lukewarm water, and then washing the skin with soap and water. Injected poison should be contained near the injection site. Keep the casualty at rest and the affected limb at below heart level to delay absorption. Snakebite. The vast majority of snakes are not poisonous. Most of South Africa's snake-related attacks are under teenagers and younger children, because teenagers and children catch the snakes to be kept as pets. Only a small percentage of snake bites are dangerous, but you should consider all bites as dangerous. Make sure to obtain and record all information. In most cases, the snake strikes swiftly and injects venom below the surface of the skin into the tissues, which is then absorbed by the lymphatic system. Should you see a snake, leave it alone. Do not attempt to kill it, as the creature will defend itself vigorously. Stay clear of likely habitats, and always pay special attention to young children playing near long grass and bush. Research suggests that only around 15% of people struck by poisonous snakes are envenomed, but always treat for the worst case, and assume that venom has been injected. Common symptoms. A non-spitting cobra, mamba, and wrinkle spite need urgent first aid treatment. Their venom generally affects the nervous system and can affect breathing. The adder and spitting cobra snake venom usually cause severe local tissue damage, with loss of tissue fluid resulting in shock. The boomslang and vine snake venom affects blood clotting and may result in spontaneous bleeding. In all cases, the first aid treatment should be to restrict circulation and prevent the venom to circulation to the heart and brain. Puncture marks. Parallel scratches on the skin, rarely any pain. Anxiety. Pale, cool skin with progressive onset of sweating. Rapid, weak pulse. Rapid, shallow breathing. Breathing difficulties. Blurred vision, drooping eyelids. Difficulty swallowing and speaking. Abdominal pain. Nausea and/or vomiting. Headache. And collapse, progressing to a comatose state. Treatment as per Tigerberg Poison Information Center. Before leaving on a hike, climbing, mountain biking, or camping trip, find out where the nearest medical facility is, and note the telephone number. In the case of a snake bite, get the patient to a medical facility as soon as possible. Phone ahead to notify them of the arrival of a snake bite victim. Note that, in most cases, you have a couple of hours before serious life-threatening symptoms manifest themselves. Immobilize the patient if possible. If alone, keep calm and do not walk too fast, or run as this speed up the distribution of the venom. Do not suck the bite site. Do not apply a tourniquet. Only in suspected neurotoxic bites, for example the mamba, Cape cobra bites, is it recommended that you apply a wide crepe bandage firmly above the bite site, as tightly as for a sprained ankle, to slow the spread of venom to vital organs like the heart and lungs. The life-threatening neurotoxic effects of mamba and Cape cobra bites, such as difficulty in breathing, develop within 30 minutes to 4 hours. If you are more than 2 hours away from medical assistance, respiratory support, for example, mouth-to-mouth resuscitation, may be necessary. The life-threatening effects of a cytotoxic snake bite, for example, puff adder, develop late. It may take 6 to 24 hours. Comforting and reassuring the patient is an especially important part of the first aid treatment. Try to get a good description of the snake. Note: antivenom should only be administered by the trained medical staff in a medical facility. Snakebite. The vast majority of snakes are not poisonous. Most of South Africa's snake-related attacks are under teenagers and younger children, because teenagers and children catch the snakes to be kept as pets. Only a small percentage of snake bites are dangerous, but you should consider all bites as dangerous. Make sure to obtain and record all information. In most cases, the snake strikes swiftly and injects venom below the surface of the skin into the tissues, which is then absorbed by the lymphatic system. Should you see a snake, leave it alone. Do not attempt to kill it, as the creature will defend itself vigorously. Stay clear of likely habitats, and always pay special attention to young children playing near long grass and bush. Research suggests that only around 15% of people struck by poisonous snakes are envenomed, but always treat for the worst case, and assume that venom has been injected. Common symptoms. A non-spitting cobra, mamba, and wrinkle bite need urgent first aid treatment. Their venom generally affects the nervous system and can affect breathing. The adder and spitting cobra snake venom usually cause severe local tissue damage, with loss of tissue fluid resulting in shock. The boomslang and vine snake venom affects blood clotting and may result in spontaneous bleeding. In all cases, the first aid treatment should be to restrict circulation and prevent the venom to circulation to the heart and brain. Puncture marks. Parallel scratches on the skin, rarely any pain. Anxiety. Pale, cool skin with progressive onset of sweating. Rapid, weak pulse. Rapid, shallow breathing. Breathing difficulties. Blurred vision, drooping eyelids. Difficulty swallowing and speaking. Abdominal pain. Nausea and/or vomiting. Headache. And collapse, progressing to a comatose state. Treatment as per Tigerberg Poison Information Center. Before leaving on a hike, climbing, mountain biking, or camping trip, find out where the nearest medical facility is, and note the telephone number. In the case of a snake bite, get the patient to a medical facility as soon as possible. Phone ahead to notify them of the arrival of a snake bite victim. Note that, in most cases, you have a couple of hours before serious life-threatening symptoms manifest themselves. Immobilize the patient if possible. If alone, keep calm and do not walk too fast, or run as this speed up the distribution of the venom. Do not suck the bite site. Do not apply a tourniquet. Only in suspected neurotoxic bites, for example the mamba, Cape cobra bites, is it recommended that you apply a wide crepe bandage firmly above the bite site, as tightly as for a sprained ankle, to slow the spread of venom to vital organs like the heart and lungs. The life-threatening neurotoxic effects of mamba and Cape cobra bites, such as difficulty in breathing, develop within 30 minutes to 4 hours. If you are more than 2 hours away from medical assistance, respiratory support, for example, mouth-to-mouth resuscitation, may be necessary. The life-threatening effects of a cytotoxic snake bite, for example, puff adder, develop late. It may take 6 to 24 hours. Comforting and reassuring the patient is an especially important part of the first aid treatment. Try to get a good description of the snake. Note: antivenom should only be administered by the trained medical staff in a medical facility. Heart attack. A heart attack occurs when blood supply to a part of the heart muscle is partially or completely blocked. The lack of oxygen to the tissue causes a part of the heart muscle to die. This is known as a myocardial infarction and may disrupt or stop heart action. Common symptoms. The patient could have the following symptoms: fear and apprehension, severe crushing chest pain, and pain in the neck, shoulders, throat, jaw, elbows, and fingers. Feeling of indigestion, shortness of breath, pallor, known as a patient that is pale, sweating, blue-gray color around the lips, nail beds, ears, and face, shock, nausea and vomiting, possible unconsciousness, and irregular or absent pulse. Treatment: give lots of tender love and care. Place the person in the half-sitting position. Assist the conscious patient to take prescribed medication. Loosen constricted clothing around the neck, chest, and waist. Treat for shock and maintain body temperature. Alert the emergency medical services and monitor breathing and pulse. Do not leave the patient alone. If the heart stops, start with CPR immediately. Angina. Angina is spasm of pain in the chest, usually caused by the inability of diseased coronary arteries to deliver sufficient oxygen-laden blood to the heart muscle. When insufficient blood reaches the heart, waste products accumulate in the heart muscle and irritate local nerve endings, causing a deep, vice-like pain that is felt beneath the breastbone and over the heart and stomach, sometimes radiating into the left shoulder and down the inner side of the left arm. A feeling of constriction or suffocation often accompanies the pain, though there is seldom actual difficulty in breathing. Pain usually subsides after 3 or 4 minutes. In acute cases, the skin becomes pale and the pulse is weak. Anginal pain may be quite mild in some cases, but its peculiar qualities can still induce anxiety. An anginal attack can be relieved by rest, or by taking nitroglycerin, or other drugs that relax and dilate the blood vessels. Angina may be stable or unstable. A stable angina is persistent, recurring chest pain that usually occurs with exertion. An unstable angina is sudden, new chest pain, or a change in the pattern of previously stable angina that may signal an impending heart attack. Angina is relatively common, but can be hard to distinguish from other types of chest pain, such as the pain or discomfort of indigestion. Signs and symptoms may include the following: chest pain or discomfort, pain in your arms, neck, jaw, shoulder, or back accompanying chest pain, nausea, fatigue, shortness of breath, anxiety, sweating, and dizziness. The severity, duration, and type of angina can vary. If you have new or changing chest pain, these new or different symptoms may signal a more dangerous form of angina, for example the unstable angina, or a heart attack. If your angina gets worse or changes, becoming unstable, seek medical attention immediately. A stroke is a condition in which a part of the brain ceases to function because its blood supply is disrupted, cutting off the oxygen supply to the brain cells. Severe strokes can cause permanent paralysis to parts of the body, or even death. Strokes can occur at any age, but usually occur in the middle-aged or elderly people and is often associated with high blood pressure. Seek immediate medical assistance. A stroke is a true emergency. The sooner treatment is given, the more likely it is that damage can be minimized. Every moment counts. If you suspect that a person is having a stroke, call an ambulance immediately. In the event of a possible stroke, use FAST to help remember warning signs. Face. Does the face droop on one side while trying to smile? Arms. Is one arm lower when trying to raise both arms? Speech. Can a simple sentence be repeated? Is speech slurred or strange? Time. During a stroke, every minute counts. If you observe any of these signs, call the ambulance or your local emergency number immediately. The patient could have the following symptoms: severe headache, Change in the level of consciousness. Unequal size of pupils of the eyes. Paralysis of the muscles of the face, with difficulty in speaking and swallowing. Numbness, or paralysis of the hands and feet, particularly on one side. Mental confusion. Loss of bladder and bowel control. A warm, clammy skin. And convulsions. Treatment. Give lots of tender loving care. Make the person comfortable, and place in the half-sitting position, to the affected side. An unconscious person is placed in the recovery position, to the affected side. Loosen constricting clothing. Do not give anything to drink. Maintain body temperature. Alert the emergency medical services. Monitor breathing and pulse and start with CPR if no breathing and pulse. Do not leave your patient alone. Diabetes mellitus. When a person is suffering from diabetes, his or her body is not able to produce insulin that is needed to maintain proper levels of sugar, also known as glucose in the blood. Insulin is a hormone, secreted the pancreas. Insulin's role in the body is to trigger cells to take up the carbohydrate glucose, so that the cells can use this energy-yielding sugar. The cells of persons with diabetes have decreased ability to take up and metabolize glucose, and as a result the levels of glucose in the blood increase. A condition called hyperglycemia, or high blood sugar. As glucose accumulates in the blood, excess levels of this sugar are excreted in the urine. Because of greater amounts of glucose in the urine, more water is excreted with it, causing an increase in the need to urinate, and the person also become thirsty. Other symptoms of diabetes include itching, hunger, weight loss, and weakness. There are two major forms of the disease. Type 1 diabetes usually arises in childhood. The diabetic person's immune system produces antibodies that destroy the insulin-producing beta cells. Because the body is no longer able to produce insulin, daily injections of the hormone are required. Without these injections, a person with diabetes will die of the disease. Type 2 diabetes usually occurs after 40 years of age and becomes more common with increasing age. People with type 2 diabetes can control blood glucose levels through diet and exercise and, if necessary, by taking insulin injections or oral medications. Epilepsy is a disruption of brain function that interrupts the normal electrical activity of the brain. Normally, neurons, which are cells that carry electrical impulses, allow communication between the brain and rest of the body. In epileptics, neurons fire or send electrical impulses toward surrounding cells, stimulating neighboring cells to fire at one time, causing an electrical storm within the brain, which results in physical changes called seizures or fits. It is only when there is a tendency to have recurrent seizures that epilepsy is diagnosed. In 70% of all cases, the cause of epilepsy cannot be identified. Head injuries, strokes, brain tumors, infections such as meningitis, lead poisoning, or injury during childbirth mostly cause the remaining 30%. There are many different types of seizures. The main types of seizures are tonic-clonic seizures, absence seizures, complex partial seizures, simple partial seizures. Tonic-clonic seizures are convulsive seizures. The body stiffens, which is called the tonic phase, followed by general muscle jerking, which is called the clonic phase, and involves the whole brain. The person loses consciousness, their body stiffens and limbs jerk. These seizures generally last up to 3 minutes. After the seizure, the person may want to sleep, or they may have a headache, or be confused and disoriented. The person may experience an aura, which can precede a tonic-clonic seizure, and this may act as a warning, giving the person time to seek a safe place before losing consciousness. Non-convulsive seizures. An absence seizure causes the person to lose contact with their surroundings for about 30 seconds, with little or no outward sign that anything is wrong. This type of seizure mainly occurs in children, and is often mistaken for daydreaming, or lack of concentration. A complex partial seizure is accompanied by impaired consciousness and recall. It may also involve staring, automatic behaviors such as lip smacking, chewing, mumbling, walking, grunting, or the repetition of words or phrases. The person may experience an aura, which can precede a complex partial seizure. A simple partial seizure produces a sudden shock-like jolt to one or more muscles, which increases muscle tone and causes movement. These sudden jerks are like those that occur in healthy people as they fall asleep. Care and treatment of tonic-clonic seizures, also known as grand mal seizures. Roll into recovery position as soon as jerking starts. Keep the patient in the recovery position by supporting him or her, and allowing the jerking to still continue freely. This will protect the patient's airway, and minimize any vomit that may enter the lungs, which can cause severe infection. Protect from harm. Place something soft under head. Loosen tight clothing and any ties. Reassure until fully recovered. Do not put anything in the patient's mouth. Do not restrain the patient. If the seizure occurs while the person is seated and strapped in, leave them seated until the seizure is finished. Support their head and neck during the seizure. After the seizure, place the patient in the recovery position if they are unconscious, or if there is food, water or vomit in their mouth. Care and treatment of other seizures. Absences seizures, also known as petit mal seizures. No active treatment required. Only reassure the patient. Complex partial seizures, known as focal seizures. Protect the patient from harm. Reassure the patient until fully recovered. Do not restrain the patient, unless he or she is at risk of injury. Simple partial seizures. No active treatment required, except to reassure the patient. One problem encountered by the first aid provider is that of the well-meaning, but untrained, bystander. This person may insist that the epileptic's tongue should be held before they swallow it. The bystander should be discouraged from actively pulling the patient's tongue out, or placing anything in the patient's mouth. Most epileptics understand what happened to them, and as soon as they recover sufficiently, they continue on with their business. They do not usually require ambulance care, and may become upset when one is called. However, as the first aid provider, you must satisfy yourself that the person is recovering normally, and that there appear to be no complications. When to call for an ambulance. A complex partial seizure lasts longer than 15 minutes. Another seizure follows quickly. Food or water is in the mouth during the seizure. It is the first known seizure. The person has been injured. The person has breathing difficulties after the jerking stops. The person is a diabetic. The person is pregnant and has a convulsive seizure. The seizure has occurred in water. The seizure lasts longer than 5 minutes. The seizure lasts longer than normal for that person. You are in any doubt. And when you arrived after the seizure has started. Asthma is a chronic disorder of the lungs, in which inflamed airways are prone to constrict, causing episodes of breathlessness, wheezing, coughing, and chest tightness that range in severity from mild to life-threatening. Inflamed airways become hypersensitive to a variety of stimuli, including dust mites, animal dander, pollen, air pollution, cigarette smoke, medications, weather conditions, and exercise. Stress can exacerbate symptoms. Acute asthma attacks are increasing episodes of shortness of breath, cough, wheezing, or chest tightness associated with a decrease in airflow. These attacks may require emergency room treatment or admission to hospital. Factors that precipitated the acute asthma episode should be identified and preventive measures implemented. Acute asthma is preventable with optimal control of chronic asthma. The cardinal symptoms of asthma are cough, tightness of chest, wheeze, and shortness of breath. Acute symptoms are episodic and are managed by self-medication with a reliever medication. Signs and symptoms may include difficulty breathing, wheezing and coughing, a tight chest, it may feel like a band is tightening around it, distress and anxiety, difficulty speaking, shown through short sentences, and whispering. Signs of hypoxia, such as gray-blue tinge to the lips, earlobes, and nail beds. Exhaustion, in the case of a severe attack. Treatment. Reassure the casualty, and ask them to take their usual dose of their reliever inhaler, which is usually blue. Ask them to breathe slowly and deeply and focusing on breathing out. If they have a spacer available, ask them to use it with their inhaler. The inhaler is more effective with a spacer, especially when being used for young children. If they have no inhaler, call for emergency help. Sit them down, in a comfortable position. A mild attack will normally ease after a few minutes. However, if they do not improve within a few minutes, it may be a severe attack. Ask them to take a puff every 30 to 60 seconds until they have had 10 puffs. Help the casualty to use their inhaler if they need assistance. If the attack is severe and they are getting worse, becoming exhausted, or if this is their first attack, call for emergency help. Monitor their breathing, level of response and pulse rate. If they become unresponsive at any point, prepare to give CPR if their symptoms improve, and you do not need to call the emergency services. Advise the patient to get an urgent same-day appointment to see their general practitioner.